Okay. So good afternoon, everyone. I hope we can all loudly hear ourselves just by sign of hand to show that you are able to get us. Okay, St. Francis, are you able to get us? Okay, that's good. UTH, Adult Center of Excellence, can you hear us? Luampa, can you hear us? Please raise your hand if you're able to hear us so that we are together as we start our session. Okay, and we'll request that everyone, where possible, switch on their videos. So good afternoon, everyone, and welcome to this 53rd session of ECHO. And this afternoon, we are privileged to have Dr. Chalilwe Chungu to present a didactic case, remotely, of course, and he will be talking about faith-based action for scaling up testing and treatment for epidemic response, and that is acronymed as FASTER. And with me, of course, here we've got our case presenter, who is Mr. Gift Mwansa, who will lead us through the case. So thank you very much. Dr. Chungu, over to you. Oh, sorry, just a minute. Madam Makupe, for a summary, a brief summary, please.
Okay, last week's ECHO session was on diagnosis of HIV-1 versus HIV-2 using rapid tests, getting it right. We discussed the approach to initial HIV testing, HIV testing procedure, as well as interpretation of results. We also discussed factors that influence HIV test results, which included window period, competency of testers, storage of testing kits, as well as quality of the specimen. It was mentioned that diagnosis error has great consequences for patients. Therefore, training and certification of testers is essential in improving quality of results. By so doing, patients' outcomes will be improved. Thank you.
Thank you very much, Madam Makupe. So, of course, to be with you this afternoon, I'm Davis Kampamba, and I'm joined by several people in the hub, here at the main hub. Dr. Chungu, over to you.
Okay, thank you, Davis, and hello to the network. So today, I'm pleased to be presenting to you an overview of the FASTER project. And as David said, this is the faith-based action for scaling under Catholic Relief Services. I have no interest or any disclosures. So the objectives for today is that we are going to introduce FASTER as a pediatric and adolescent focused project. This is exciting because there's a lot that can be done in this arena. So FASTER is a consortium partnership between Catholic Relief Services and Clinton Health Access Initiative, CHI. We are also going to look at the priority areas for FASTER and some of the strategies that FASTER will undertake. Next slide, please.
Okay, so maybe at this point in time, let's see how much knowledge we have, especially concerning this population, adolescents and children. Very key when it comes to HIV and its management. So from this end, let's see, Chalilwe. Okay, just hold. Yes, Chatonda. Sorry, just trying to launch a question. Otherwise, that's our very first question. Who should be prioritized for HIV training? Who should be prioritized for HIV training for best adolescent outcomes? Is it A, adolescents, B, healthcare workers, C, caregivers, or indeed D, all the above? So all the three that are above. Who should be prioritized for HIV training for best adolescent outcomes? Is it A, adolescents, B, healthcare workers, C, caregivers, or D, all the three? So far, there is overwhelming response concerning D. That is all the three. And we have about 32 people, 32 that have voted. I know we are more than that. Okay, we've got about 15 seconds. Who should be prioritized for HIV training for best adolescent outcomes? So Dr. Chungu, you can see that you've got some work to do to win the hearts of the other three, if at all D is the best answer. So we've got about 8% going for A, then 5% going for B, and just about 2% going for C, and 86% going for D. Okay, thank you very much. Let's move to our next poll. The next question is regarding optimized pediatric regimens. A, pharmaceutical companies prioritize manufacturing pediatric regimens over adult regimens. B, NVP phase out should be done to have children on efavirenz-based regimens. C, adolescents weighing more than 15 kgs, adolescents weighing more than 16 kgs should be put on DTG containing regimens. D, lopinavir/ritonavir is the preferred adolescent regimen. And E, none of the above. So that's our second poll question regarding optimized pediatric regimens. Pharmaceutical companies prioritize manufacturing pediatric regimens over adult regimens. B, NVP phase out should be done to have children on efavirenz-based regimens. And then C, adolescents weighing more than 15 kgs should be put on DTG containing regimens. D, lopinavir/ritonavir is the preferred adolescent regimen. And E, none of the above. Again, very interesting looking at the responses. Keep them coming. So again, the last choice is pulling the rest. So we have about 65 going for none of the above. We still have A, C, and D having some respondents under there. Okay, thank you very much. We shall hear more as Dr. Chungu goes through the didactic presentation. The third polling question. Okay, just a minute. Which one of the following trainings is of highest priority to make you more effective as you see pediatric and adolescent clients? Is it A, adolescent HIV management training, B, pediatric HIV management training, C, consolidated HIV training, or indeed D, smart care training? That's our third polling question. Please keep them coming.
Change the slide also, it's still showing.
Okay. Keep them coming. So we have almost everyone going for C. Again, of course, the votes are divided. We have others going for A, about 3%, B, about 10%, and D, about 3%, with C getting about 86%. Which one of the following trainings is of highest priority to make you more effective as you see pediatric and adolescent clients? Is it A, adolescent HIV management training, B, pediatric HIV management training, C, consolidated HIV training, or D, smart care training? And with that, we end our polling. Okay, thank you so much. Dr. Chungu.
Yes, David.
I'm sure you keenly followed the polling from the spokes.
Yes, I have.
Yes, it's very interesting that almost all the choices had a good number of followers. So let's see what we can get from this session. Go ahead, Dr. Chungu.
Okay, thank you. So, introduce a FASTA project to everyone. As a way of background, only about over half of children living 0 to 14 have access to ART. This is at the global level, compared with adults who above 60%. But we know that, of course, there's been a lot of activity in this space, and the numbers have slightly increased. When it comes to adolescents, the coverage of adolescents living with HIV is largely not very known because of the lack of disaggregated data. Despite new infections in children having dropped, there's been a lot that has happened in terms of PMTCT, but HIV remains a significant challenge, especially in children, in reaching the 2020 UNAIDS targets. So what does Zambia data look like? So we have low case identification rates. Out of the 60,000 children estimated to be living with HIV, we have a treatment gap of about 10,000 of them. With that, about 1,000 are not linked. And then in terms of viral coverage, we're just above 50%, and with low viral load suppression rates of around 60%. So there's still a lot that can be done in terms of pediatric and adolescent HIV. So from interacting with partners, with facilities, with the Ministry of Health, key informant interviews, the major themes that come through in terms of gaps in like pediatric HIV is long turnaround time for EID results. There's also gaps when it comes to following the cohorts of mother-baby pairs. And then also there's the Know Your Child HIV strategy, which is an index testing strategy where the mother is an entry point to identify her children, but there's suboptimal implementation of this. Healthcare workers, sorry, before that, before we move on, previous slide, healthcare workers consistently talk about the need for pediatric training. I'm surprised actually that a lot of us feel that we need consolidated training. That's a surprising need, noted. And then also formulations for PIDs, sometimes a challenge, and then phlebotomy is a challenge as well. Disclosure issues, as well as an adolescent package is not widely implemented. So it was noted that there are all these issues around pediatric HIV. So the Pope, there was a high-level dialogue meeting in 2017, November, where in Vatican, faith-based organizations, pharmaceutical companies and diagnostics, NGOs, governments, and agencies came together to just chat and discuss what can we do regarding pediatric and adolescent HIV. So in August of 2018, the Pediatric Agenda Consortium, supporting the Rome Action Plan, endorsed 6 priority action areas that would be the focus, and hence gave the birth of FASTA. So FASTA is a CDC PEPFAR-funded project. The duration is through to September 2020, and the implementing partners, as I said, are Catholic Relief Services and the Clinton Health Access Initiative. So in that high-level meeting, it was noted that 4 countries should be prioritized for this project, and these are Nigeria, Uganda, Tanzania, and Zambia, based on the treatment gap and the unmet need in pediatric and adolescent HIV. So the main mechanism for how FASTA operates is it works through the Ministry of Health, through the National Technical Working Group, particularly the Pediatric and Adolescent subgroup, and working through all the implementing partners regarding pediatric and adolescent HIV issues. So remember I mentioned that the Rome Action Plan came up with 6 priority action areas regarding pediatrics. The first is working with governments and regulators on approval processes. It's been recognized that sometimes you have a new product, be it a diagnostic or a drug that comes on the market, but that there's sometimes a delay in the way these products are adopted in countries. So what's envisioned is that we need high turnaround time for lab equipment and commodity approval, and we need standardized processes. So CHAI is working strongly on this one to ensure that we have standards for approvals, as well as that we have expedited, adopted approval of commodities as they come in country, right from adoption to operationalization. So priority action 2 is, as we make headway in terms of pediatric and adolescent programming, there's need for integration of all partners, including faith-based organizations and MOH. So for Zambia, there's very good collaborations between the Ministry of Health and faith-based organizations. We have CHAS, we have CRESO, but in order for us to achieve epidemic control, you will agree with me that there's need for stronger collaborations. So priority action 3 was expanded diagnostic platforms. I think the network will agree with me that point of care is such a big trending topic, and we really need to make sure that the services are expanded to cover every portion of the country. So with this, there's a mapping exercise, which is mapping where are these machines found, where can they be placed for maximal impact. And so that what's envisioned is a strategic scale out of point of care devices. And as these devices are scaled out, there's need for support supervision. So we know that the GeneXpert platform has been approved for performing EID diagnosis, as well as viral load, in addition to what it currently does. So with that, there'll be need for a proper coordinated mechanism, monitoring and evaluation of what's going on. So priority action area 4 is evaluating novel HIV testing approaches. You'll agree with me that since there are very few kids left out there, very few adolescents, we need to be very strategic in the way that we perform HIV testing. Under FASTA, there's an OraQuick study which is supposed to generate evidence. So this is a caregiver-assisted study where caregivers are given HIV self-testing kits. They then get these test kits and go and test their children at home. So it will be compared whether parents find this as a better alternative to the standard of care where they bring in their children to the facility, or where they ask for community staff to test their children at home. So we are very excited that this will give us evidence as to the usefulness of this modality and how it can be scaled up. And the root cause of this was noted that sometimes there's caregiver refusal for testing children, but will this be an approach that makes testing more appealing to parents? So PA5 is implementing validated HIV risk screening tools. In the same line of saying that as we have fewer people to reach for HIV diagnosis, we need to be very smart about this. And so the Ministry of Health has rolled out risk screening tools. What remains now is to make sure that they are being implemented with fidelity. So we need to make sure that we're implementing them uniformly in a coordinated manner and collecting data in order for us to optimize the yields from HIV risk screening tools so that we can test with efficiency and use our resources to give us the best outcomes possible. So the final priority action area that came about in the Rome Action Plan was that we need to optimize pediatric ART formulations. If you remember, in our discussion, we're saying that farmers, and that's not You find that adult regimens are prioritized because they have bigger volumes. And then we've been talking about NVP phase out. And the plan is for us to phase out NVP not to prioritize efavirenz, but so that we can put adolescents on potent regimens, of which the priority is DTG containing regimens. It's once a day. It works quickly, so it lowers viral load quickly. So those are some of the benefits that are there. So adolescents need to be optimized to be on DTG regimens when they meet the threshold of being 20 kilos and above. So we know that we've had recurring revisions to treatment guidelines. And that means that with recurring revisions, frontline workers need to be empowered with knowledge, with supervision, and a platform such as ECHO. If you see that big arrow, it's pointing to ECHO to just show that ECHO is a rapid solution that makes sure that we have a mentorship platform, and then we also have mentors through the mentorship initiative. So that's a quick way that we can get some of this quick information out to the network quickly. So what are some of the strategies that FASTA is going to use in order to catalytically work with everyone to achieve viral load suppression? So the first is optimal point of care placement. CHAI will work with CRS and all partners and the Ministry of Health to develop an EID dashboard. So this is a dashboard that is going to show all the data coming from these point of care devices that are optimally placed. I mentioned the fact that we have strong linkages, but we need strong community linkages and referrals as well. As clients are moving from one facility to another, we need to be able to know where clients are coming from so that we can know. In this era, customer service and quality of services is very important because it's quality that's going to make sure that our clients are retained in care. There's a pediatric change package, which is basically a model that will be employed in some of the FASTA sites to ensure that there is ownership regarding pediatric issues, having a champion at a facility, having coordinated processes. This was developed under the Ministry of Health, and it's going to be re-rolled out with improvements on what is currently pertaining. As regards adolescents, we know that in Kenya, for example, there's the Operation 000 model that looks at 0 missed appointments, 0 missed doses, 0 viral loads in children. And so the plan is to adopt a focus like that in Zambia and just roll it out where adolescents are the owners of their care. In order for us to achieve adolescent HIV management, we need all players on board, the adolescents themselves, the caregivers, as well as healthcare workers, in a model that sees adolescents as taking charge of their care rather than it being shoved down by the healthcare worker or it being the responsibility of parents. Mother-infant pair retention is something that we are strongly committed to, and viral load cascade management, including phlebotomy training for those sites that indicate that they need a need in terms of phlebotomy training. We've been talking about DTG and how it needs to be scaled up. And in the not so distant future, we'll be having improved formulations even for younger children. So we might have DTG 10 milligrams, for example, coming onto the market. As we have all these things that we are talking about, we'll need data, and so we need to strengthen M&D systems so that whatever information decisions are made are based on data to have a data-driven response. And whatever is working needs to be scaled up at the national level, and whatever is not working needs to be modified and see how it can be improved. And all this, we mentioned that we'll do this through highly trained pediatric-focused mentors, not to duplicate, but to complement the current existing mentor pool that is happening. So Mwansa, who's in the hub in PCOE, is one of our mentors and is going to present a case shortly. So in summary, FASTA aims to work with everyone in the area of pediatric and adolescent HIV, working through the HIV Technical Working Group, particularly the pediatric and adolescent PMTCT subgroup, as well as the adolescent unit at the Ministry of Health. The plan is to have quick scale-up of proven interventions. And with all this, we hope that we can collectively, not that we hope, we will collectively achieve epidemic control. Thank you. Davis?
Thank you very much, Dr. Chungu, for that lovely presentation and wonderful facts actually coming out as it relates to pediatrics and adolescents, and especially with some of our background. It's very sad to see the prioritization actually just going towards the adults and the peds and adolescents, especially peds, lagging behind if we want to eradicate this epidemic. So I'll invite Dr. Thomas. Are you with us? Any comment from the expert before we go to the poll questions, or any response from the spokes? Any comments, any questions as it relates to what Dr. Chungu has run us through? Very informative. I'm sure we will all agree. So silence means yes. Any comments, any questions for Dr. Chungu is still with us concerning what has been presented? So was it straightforward? Everything understood? Well assimilated? I can see Mary Boyd nodding vigorously. That's very good and assuring. Dr. Chungu,
Yes, David.
You've got a thumbs up from Mary Boyd that everything went well.
Thank you, Mary Boyd. And just
Okay.
to the network, just to say that from the training needs that I saw before, I'm optimistic, and I hope that we can get a lot more adolescent and pediatric training out there. Just to anecdotal, you hear people say that that's the gap that they perceive. So that for me is something that is noted.
Okay, so
Sorry, Davis. Vanessa has raised their hand.
okay. Which one is the rest?
Vanessa.
Okay, Vanessa. Vanessa, yes, please go ahead with your question or contribution.
Yes, thank you so much for the wonderful presentation. I just wanted him to elaborate more on the use of HIV self-test in adolescents and pediatrics. I think I didn't get the points clearly.
Okay, Dr. Chungu. Okay, so yes, I got her question. So I mentioned that under priority action area 4, where we talked about the use of novel case testing approaches. Under FASTA, there's a study called the ORAQUIC study, which is caregiver-assisted use of HIV self-testing kits. So in this model, parents will be given HIV self-testing kits to go and test their parents at home. It will be done not everywhere, but in 15 sites. So the purpose of the study is to generate evidence on how acceptable, how feasible, and how effective is it when you give parents kits to go and test their kids at home. The current standard of care is that if you want, like for example, you want to index a child from a positive mother, you either ask them to come to the facility or you follow them at home. So what the gap there is that caregiver refusal for testing of their children is high. So based on that, what we hope to see is how acceptable is this, and if it's acceptable, then it will be a modality that we need to prioritize in terms of using HIV self-testing kits for testing children 0 to 14. Adolescents 16 and above under the HIV self-testing model are able to collect self-testing kits from the facility. So this is for 0 to 14. Sorry, 18 months to 14, because 0 cannot be tested using that modality. We need to confirm with EID. 18 months to 14.
Okay, thank you very much, Dr. Chungu. I hope, Vanessa, you are very clear with that response. Any question from the spokes? Please, if you have a question, raise your hand. Any question before we go to the poll questions?
Hello.
Okay.
Hello, I
Yeah.
have a question. I don't know if it's a question or a comment.
Okay.
On the study using the oral test for children, our current guidelines are that we are using biological tests up to 24 months. So would you like to maybe revisit your age range for the study, Dr. Chungu?
Okay, that's noted, Dr. Moviana. It's based, so that's noted.
Yeah. Thanks.
Okay. So thank you very much. So we can quickly go into the poll questions. You can launch, please. So I hope with what has been presented and the questions asked from the spokes, we are going to get 100% this time around. So the first question, who should be prioritized for HIV training for best adolescent outcomes? Is it A, adolescents, B, healthcare workers, C, caregivers, and D, all the three? Okay, that's very interesting. 100%. Oh, I was too quick. I was too quick to speak. Okay. Again, we still have some split votes. Let's keep the votes coming.
All three.
So we have about 3% going for adolescents, about 8% going for healthcare workers, and 0% caregivers, and about 88% going for all the three. So we still need, Dr. Chungu, we still need some disciples to follow us. Yes, so thank you very much. We'll close the polls. Dr. Chungu, what's the best answer? Dr. Chungu.
Yes, Davis. So I think the majority are right. You need all three. Remember, I said under adolescent models, everyone, traditionally you can see like from the response that 11% think healthcare workers are priority. And indeed they are priority, but you recognize that for optimal adolescent outcomes, you need to also train the adolescents themselves as well as caregivers as well. So like under the Operation 000 model, within a 3-month period of instituting training to caregivers, adolescents, and healthcare workers, they were able to see a shift in viral suppression from a baseline of around 70-something% to over 90% when you prioritize all three populations and other added interventions as well.
Thank you very much. The second poll question. Regarding optimized pediatric regimens, A, pharmaceutical companies prioritize manufacturing of pediatric regimens over adult regimens. B, MVP phase out should be done to have children on efavirenz-based regimen. C, adolescents weighing more than 15 kgs should be put on DTG containing regimens. D, LPVR is the preferred adolescent regimen. And E, none of the above. Again, overwhelming response for one particular answer. However, we still have split votes, others going for B, others C, and a good number going for E. Please keep the votes coming. Many of us are not voting. I don't know why. Okay, regarding optimized pediatric regimens, pharmaceutical companies prioritize manufacturing pediatric regimens over adult regimens. MVP phase out should be done to have children on efavirenz-based regimens. Adolescents weighing more than 15 kgs should be put on DTG containing regimens. LPVR is a preferred adolescent regimen, and D and E, none of the above. Okay, so 2 seconds. 1, we close the poll. Dr. Chungu, again, we have about 78% going for none of the above. This question had no answer, in other words. So what is your take?
Yeah, so thank you, Davis. And yes, that is the right answer, that there is no answer. I know that sounds contradictory. So yes, because we, like I mentioned, because the numbers are more among the adults, so it's more profitable to have adult regimens. And because of that, CHAI works with governments to sort of pull pediatrics together and then negotiate like reduced costs for drugs based on this pooling across countries. And then NVP phase out, we said priority should be that, because it's NNRTIs, the priority should be that we should have children on more potent formulations that are more palatable and easy to administer. And DTG is a very good preferred option right now, and that will be emphasized in the upcoming guidelines that will be launched at the national conference. And then also DTG in the current setup is approved for more than 20 kilos, and like I said, DTG is the preferred regimen. But allow me, there's a question from Bill. Bill asked what Operation 000 is all about. I love that Adams from the chat, and then Adamson has responded. So there'll be more information regarding Operation 000 and having an adolescent model. So maybe we can have a subsequent presentation focused to adolescents later, but just it's nice, Bill, that you're asking. So like I said, it's adolescent-led care that improves outcomes where adolescents are involved in their care. We've had meetings with adolescents. They are very excited to be in the forefront of designing a model that speaks to the needs that they perceive that they have. So look out, this is very exciting stuff. And I think in the next months to come or weeks to come, we'll see if we can have a platform where we can discuss adolescents in detail.
Thank you very much, Dr. Chungu. And the last but not the least, which one of the following trainings is of highest priority to make you more effective as you see pediatric and adolescent clients? Is it A, adolescent HIV management training, B, pediatric HIV management training, C, consolidated HIV training, or D, smart care training? Again, it's either some of us were dozing during the presentation, one answer was strongly disqualified, and we still see people going for it. Anyway, let's see. So which one of the following trainings is of highest priority to make you more effective as you see pediatric and adolescent clients? Is it A, adolescent HIV management training, B, pediatric HIV management training, C, consolidated HIV training, and D, smart care training? We've got just about 15 seconds. Please keep the votes coming. Very few of us are voting, but there is a tie between B and C, pediatric HIV management training and consolidated HIV training. So which is which? Okay, 5 seconds. Okay, time up. So Dr. Chungu, we have about 2% going for B, which is pediatric HIV management training, and about 54% going for consolidated HIV training. You will be the judge.
Yeah, so this wasn't one of those right and wrong answers. It was mainly like killing two birds with one stone, like a survey just to see what do people perceive as what you need to feel confident and to be equipped to better manage children and adolescents. So I've noticed that after this, the response has sort of shifted a bit to pediatric coming second. I'm sure Dr. Thomas, Dr. Muviana, and Dr. Muya are excited about this. So the fact that, you know, this is seen as a need is definitely exciting, and we hope that those training needs or expectations can be met through several platforms, including ECHO, I think, which is the reason why we're having a session like this one.
So thank you very much, Dr. Chungu, for that lovely presentation. And we now go, okay, let's just consider the chat. Okay, we'll just read maybe two responses in the interest of time. From Mongu Chess Clinic, you put the best strategies, but of concern is the DBS results. TAT that has been long in the rural areas from PCR labs. Any considerations to put up a strategy in line with TAT of results, as lately Mwana program has not been so active to quicken the process? Dr. Chungu, in 30 seconds.
Yes, so like I mentioned, this optimization process that is being undertaken also works in line with system strengthening, so meaning optimizing referrals. So like I said, this is not like, it's work that's being done through the Ministry of Health, through the technical working group, with all partners coming together. So that's noted, and I'm glad Mongu says that, because the next case is actually a case of Mongu. So after maybe the presentation, we can even have further discussions, because it speaks to some of the questions that the point you've brought about. Over to you.
Thank you very much, Dr. Chungu, and thank you everyone for your attention. Okay, in the interest of time, we'll straight away go into our case presentation this afternoon, and we are privileged to have Mr. Mwansa, Gift Mwansa from Yuka Mission Hospital to present today's case. Over to you, Gift.
Thank you very much. Okay, so as Elia mentioned, my name's Mwansa Gift. I am a pediatric clinical mentor at Yuka Mission Hospital, working under the FASTA project. So basically, some brief background before we get into the details. Yuka Mission is a hospital that's in Chalilwe district of Western Province. So Chalilwe district actually has two hospitals. There's Yuka Mission Hospital and Chalilwe District Hospital. So then Yuka and Chalilwe were two of the first facilities to start offering ART in the district. And so because Chalilwe is a town that is close to the borders of Angola, we get to have clients from as far as Angola, and there are a lot of clients that come from very distant places. So our case here is a case of a 5-year-old child of Lola village that's approximately 100 kilometers from Yuka Mission. So the child is under the care of her grandmother, as her parents are divorced and the mother remarried. So the child was commenced on ART basically in 2016, and the child was commenced on ABC3TC and Lopinavir-Ritonavir. So the following things have been noted. The child has no lab test results documented, except for viral load, which was on the 15th of April 2019, recorded at 2,043 copies per mil. The child does not attend, the child and the guardian do not attend EAC sessions, and adherence has remained a very big problem. So basically this can be seen in the repeat viral load coming out as 4,281 done in August 2019. And this was actually collected during a campaign because the child and the guardian did not go back to the facility and they were nowhere to be found. So during a campaign, they were able to trace them and the viral load was done. So the child's nutrition and growth is not well monitored. Then the client's drugs are actually picked by community-based volunteers who actually are not able to adjust doses for this client. So a brief clinical timeline and lab results. The child was commenced on ABC3TC Lopinavir-Ritonavir in 2016. Then the test done was an HIV test of which the child's status was positive. Then the child was initiated on the drug that I just mentioned earlier. A viral load, the only two documented viral loads were done this year. The first one being on the 15th of April 2019, and the viral load was 2,043 copies. The child was enrolled into EAC, and as I mentioned earlier, has not been attending. The next viral load was collected in August on the 26th, of which the results showed 4,281, and there was no documented action. Other than that, there is no evidence of any other clinical lab results. So basically, as I mentioned earlier, that's just a picture showing us the route that people have to take to get to the facility. They actually have to cross a river. If you are to go for mobile clinics, you have to use a pontoon. So our questions are that, firstly, how best can we help this client, or probably clients that also fall in this group, how best can we help them? Then the second question is that, should MMS be introduced in this child? And if so, how would doses be adjusted, especially in children below the age of 5? So should we consider 3 months, 6 months MMS in such clients that come from distant places? Then the third question is, should we consider training community assistants in adjusting of doses as part of the solutions?
Okay, thank you very much, Gift. A very interesting case, and I'm sure we've seen several challenges highlighted here. And just straight away to go into the summary of this case, this is a 5-year-old who stays quite some distance from the healthcare facility, 100 kilometers to be specific, and is under the care of a grandmother, seeing that the parents are divorced, and the child is on ABC 3TC lopinavir, ritonavir, and the child's viral loads have been unsuppressed. The first one that is recorded being about 2,043, and the second one after EAC, which he does not even attend, attempt of EAC, which he does not attend, about 4,281. The other issue is this is a child whose drugs, whose nutritional status and growth are not monitored, and the clients are being picked by CBVs who have no capability to adjust the doses. And of course, the child does not attend EAC, as we had said. So our question is, how best can we help this client? Should MMS be introduced in this child? And if so, how will the doses be adjusted, especially in the children that are below 5 years? And then lastly, should we consider training healthcare or community assistants in adjusting doses? As we have seen in this particular case, they are unable to adjust the doses for this child. So this is the case for today, and we hope that as we go into our breakout rooms, we are going to come up with very good solutions that shall consider the challenges that have been presented before us in this child. Remember, it's not just this child. We have several children out there that may be in similar situations at the facility that has just been given us this case, that is Yucca Mission Hospital. Thank you very much. Okay, AIDC, there's a question Sombo?
Yes, Davis, thank you very much for that presentation and for the pictures. Well done to the presenter. There's a question here.
So we would like to know what the initials MMS mean.
This is from here. They want to know what MMS stands for.
Okay, Dr. Sombo. Yes, Gift. What does MMS stand for?
MMS is basically multi-month scripting, where we are considering giving drugs to the client for a number of months.
Those that are stable.
Those that are actually stable.
Yes, and there's a definition for stability. Okay, I hope that is very clear.
Thank you so much.
Okay.
Thank you so much.
All right.
Why the child's growth was not monitored? Is it because the child wasn't growing, or there was no scale? What are the challenges at facility level that caused the child not to be monitored for growth?
Yes, Gift.
Okay, so basically, the facility has scales and everything that is needed, but the challenge is that the child hardly comes to the facility. There is no clinical interaction between the child and the facility. So when the child comes, the weights and everything else are actually collected, but this is not consistent. So you're unable to monitor how the child is progressing, at which point probably they might be on the dropping end of the chart, or at which point they are actually progressing, or that monitoring process is not actually in place.
So maybe with such a response, the question that one would ask is, we have CBVs that have contact with this child. are they really in contact? Do they find this child? Because if monitoring is that difficult, then how can we utilize these CBVs that are getting these drugs to take to the child?
Okay, so for the CBVs, as earlier alluded to in the introduction, the child stays with the grandmother, and at times the child has to go to the parents' home. So at times the child cannot be found at the grandparents' place, and the mother's place is actually outside the district. So the child has to be monitored when the child is at the grandmother's place, of which that hasn't yet been happening.
Okay, very interesting. Okay, Dr. Foloshi, okay?
Yes, thank you very much. Well done.
All right, thank you so much. So we now break out and see you soon. Enjoy your session. Just 15 minutes. Thank you.
You have a question from George.
Okay.
Was the child on Septrin on that first high viral load?
Okay, quick one before people disappear into their groups. Was the child put on Septrin with that high viral load?
Yeah, the child was actually on Septrin, except it hasn't been documented in the presentation.
Okay, so the child is on Septrin, or was on Septrin.
I have a comment on that, Davis.
Yes, Dr. Chungu.
So this child's eligibility for Septrin is not based on a high viral load, but on the age, which is less than 5 at that time when there was a high viral load. So
Yes.
the eligibility for Septrin should not be the high viral load.
Thank you for that. That's very true. The child is 5 and below, under 5, they are eligible for Septrin regardless of their viral load or CD4. Thank you so much. Okay, so are we good to go? Okay, so we have everyone, we follow. Very far from the health facility, 100 kilometers. That's almost like Kafue.
Kafue is 50.
50, you see, I don't, so it's beyond Kafue. And is under the care of a grandmother. The parents are divorced, so I'm sure we know the challenge that would come with that as well. We're not given reasons why they are divorced, but care would definitely be compromised. ART was commenced on the 31st of October when the child was 2 years old on ABC3TC alluvia or Caletra. And the following has been noted. The child had a high viral load. The first viral load was quite high, which was 2,043. And then moving on, a repeat viral load was 4,281. And of course, that was after an attempt to have this child enrolled into EAC or enhanced adherence counseling sessions, but the child, it's been problematic. It's been a problem to have this child enrolled into EAC sessions. And the nutritional status and growth, as we heard, is not monitored because of those challenges. This time the child would be with the mother, and the other time the child would be with the father or even the grandmother and all those things. The client's drugs are picked by CBVs, community-based volunteers, who actually do not know how to adjust doses that are supposed to be given. And remember, this is at a backdrop where the growth is not being monitored and the nutrition, of course, should be poor. How best can we help this client? That's the first question. So any responses will be welcome. How best can we help this client? Okay, let's feel free. So far, we have no hands up. Please, as if you want to speak, you can unmute yourself. Okay, Dolly. Dolly.
Yes, good afternoon.
Yes, good afternoon.
Thank you. I just wanted to comment on how we can help this child.
Yes, please.
I think the first thing we can do is help in adjusting the dose, of which we can do that by maybe sending the same community health worker who's taking the drugs to be weighing the child every time they're taking the drugs. Then the drugs can be adjusted from the hospital, wherever they're taking them from.
Okay, so the challenge has mainly been that they do not know how to adjust. So is it that it's related to them not knowing the weight of the child, or they just don't know how to adjust these doses?
Okay, so basically, if you look at the kind of CBVs that we have in these areas, these are areas where you can find a well-trained psychosocial counselor. And so you'd find that you look at where clients come from, you map the clients, then you look at, you advertise depending on where the client comes from, who's in the area, so that it can be easy for us to reach these people. So basically, these people are not highly trained. Like, they are not the ideal CBV would have a psychosocial counselor or something like that. So their competence levels are a little bit low, so it's kind of hard for them to adjust.
Okay, so I guess as we are tackling question 1, we will also be siding with question 3, because the two are somehow related, I suppose, especially as we consider what Dr. Chungu has talked about concerning trainings of these people. Okay, so we've heard that these are people that are not ideal, so to speak, but it's just that after mapping, you have these people in the vicinity of the clientele that you have, and therefore, I suppose they would need training, unless otherwise. What does the hub think? Okay, so unanimously, people are saying these people that we deem not to be ideal need to actually be trained. Okay, Dr. Chungu, any comment from your end?
Well, I'm following the discussion because I remember preliminarily one of the discussion points that was coming out was saying, you know, like I think because as healthcare workers, we always insist that we should be the ones to adjust doses and decide, you know, like what treatment to give. So what makes this case unique is we are faced with a scenario where this is not possible. You get it? So if we adhere to those rules that we've sort of set, we have a real case before us, and we need to chart like what's the best solution. So I would love to, again, I don't have like an answer, because this is one of those cases where, you know, it requires you thinking outside the box and having like solutions that might not necessarily fit into guidelines, if you may. So then that's why I'm interested to hear what other people feel or think would be best for a child like this. And by the way, maybe just to bring it to context, 100 kilometers. To walk 100 kilometers is like walking from Lusaka to Midway to Kabwe. So this means that these people even sleep sometimes during the way, just to go and get treatment.
4 days, we are told.
Yes.
It takes 4 days.
4 or 5 days.
Yes.
Coming and 4 or 5 days going.
Okay. Yes. A comment?
Yes, I wanted to find out how far the mobile ART goes, and if it goes somewhere near, if mobile ART can also be of help. So another part of the distance, and then the.
Okay. So the question here is how far the mobile ART services reach in our facilities.
Yeah, so when we do mobile ART services, we're able to reach these clients, except that mobile ART services are not sustainable. Yeah, you might not always go for mobile ART services, and what happens when the partners pull out?
Okay.
Yeah.
So a question that can be asked, maybe Gift, is have we as healthcare providers attempted to go with some of these CBVs, one of those visits, because the training has not been done? We wonder what the child is taking right now, but have we as a facility even just sent one person to go and accompany these CBVs and just orient them or see how the child is doing? Because that one would be an immediate solution for now.
Yeah, so basically the last time a health worker had an interaction with this child was in August when we had the viral load campaign.
Okay.
So the child was followed up as the other clients were. Then they had that interaction. The recent mobile ART clinic that we had was last month, and unfortunately the child was not at the grandmother's place.
Ah, okay. So that is one of the solutions, actually, like once in a while when the CBVs are going over, the healthcare provider goes with them. Any other comments before we move? Okay. Okay. Nathan, just hold on. We'll get back to you soon.
So I just case, one of the problems we have with the drug itself, aside from accessing healthcare facilities, accessing health services, the loperamide Calitra is a syrup, first of all, and we don't know how the grandmother is measuring it in terms of actually giving the dose. So the syringes which it comes with have got small graduations, which are quite difficult to measure, especially for somebody who's either illiterate or has not got very good eyesight.
Mm-hmm.
Secondly, this drug requires cold chain storage. So depending on how many months they were dispensing for, if we're not assured that the Calitra was being stored correctly, it could also have been losing potency, which could also contribute to the high viral load.
Okay.
So I think we should consider engaging medical stores and perhaps getting the tablet formulation, which is 100 milligrams over 25. So if the child is able to swallow a small tablet, that might be a better option for this.
So you said 100 against 25?
Yes.
Tablet.
Mm-hmm.
Okay. Okay. Yes, Nathan. Thank you, Mkumbi.
Yes, sir. Good afternoon. Nathan here.
Yes, please.
So that was indeed a very interesting case. I just wanted to seek some clarity, because if I heard very well in the presentations, the group being considered to be trained, is it the community health assistants or the CBVs? I just want to really seek clarity on that, because really this is a case which has presented with special circumstances, of which really, if we really were to bend to the guidelines, we may be missing out. We may be not be providing the care which this child is, considering the distances, because already there's some breakdown in the family-centered approach to this child and everything. So are these the community health assistants? Because I believe these have undergone some level of some training, and from my experience, these people are also being used even at facility level to dispense some drugs, of which, if they are community health assistants, really, there are people I feel they can be trained to do the dosing and be able to reach out to the child. So just want to seek some clarity. Are we looking at CBVs or community health assistants? Thank you.
Okay, so Dr. Nathan, these are CBVs, as it was outlined in the case presentation. They are community-based volunteers.
Oh, okay, all right, thank you very much.
Okay, and then of course we've got a comment from one of us who's saying the facility needs a caregiver support group which will help the child's guardians to understand and learn how to manage the child, and then adherence to appointments that are scheduled, and then also engaging the family for treatment support. It's been very difficult. I guess the facility has tried to engage the family. It's been very, very difficult for this particular case. But I think from the facility point of view, the point that has been raised is very important. A caregiver support group from the facility, that it needs to be guardians. Okay, any other comments? I'll move to the second question. Yes, Amangaba.
Yes. Good afternoon.
Yes, good afternoon. Let's be quick, less than a minute.
Yeah, I'm thinking if the CBVs who takes the drugs to that child stays near, it's another way that we can engage the same CBVs to ensure that the child is taking the medication on a daily basis. I think we had a similar situation And this is what we did actually. We engaged the caregiver, the CBVs. We involved him. We said he should go there and ensure that the child takes the medication. And going by what Dolly said, I think if the same CBVs is able to reach there, the same CBVs, we don't know how which criteria we can use, maybe to give him or her a lighter scale to go and maybe weigh the child, and then brings the weight to the facility so that the people in charge there, they can change the dosage and give according to weight. I think that weight can also help. Thank you very much.
Thank you so much. So I hope we are good to go with those points. Yes. So the first one, CBVs to be trained or oriented, healthcare workers to have an interaction at least with this child, or also engage MSL to see if they can supply the 100/25 milligrams tablets, engage the family for treatment support where possible through the CBVs, and then again engage these CBVs where adherence issues are concerned as they come to pick the drugs, and also show them how to do depending on the weight that can be exhibited at a facility. I think that those are the things that have come out so far. Do we all agree? Okay, so we move on to question 2. Should MMS be introduced in this child, and if so, how will doses be adjusted, especially in children below the age of 5? We will be ending our session soon, so let's be quick. We've got about 2 minutes or so. So question 3, like we said, we have already answered it. Yes? Anyone from the hub? Okay, please, you can speak. Good afternoon, thank you.
Looking at the adherence of this child,
just speak up, please.
Sorry?
You can come closer to the mic.
Okay, yes, go ahead. In less than 30 seconds.
If I got the scenario correctly, the MMS is meaning getting drugs for a long time, yes?
Yes.
Looking at the adherence of this child and looking at the viral load, it's not possible to have the MMS for this child because this child needs to be stable with adherence and also the viral load, but with the poor adherence and the viral load, it's not possible.
Okay, what do the others say? I hope we heard that MMS is not ideal in this particular patient. We've got about a minute to closing this breakout session.
Can I comment?
Yes, please.
Probably a brief comment. I was also looking at it in terms of considering other children, because we might not only concentrate on this child, we might also have other children. So if we've got stable clients in this age group, how best can we manage them? Trying to cut down on the distance. We want to reduce how many times they come to the facility. So how can we distribute drugs to them? And how are we going to adjust doses if we give them for a lot of months? So I was also looking at it in those zones.
Okay, yes, there was a comment from my end this side.
If it's in a tablet form, mouth drug maybe would be okay, but obviously I'd emphasize on the storage. But if it's a syrup,
it's passing through the issues of nutrition, the issue of making sure that the child is getting quick doses. So all those challenges that the pediatric care comes with. So we need to be careful when it comes to pediatric care. Thank you.
Okay, thank you. I think
the third question, training is needed, is very paramount in this particular case.
Yes.
So just before we go, so MMS is not ideal in this particular child. However, we can offer self-centered DSD model if possible, okay, as long as we engage healthcare providers taking a visit to this child's home at least once in a while or once in a month or something like that. Is that okay?
Yes, yes, monthly.
Monthly, yeah, monthly visits by the healthcare providers with a CBVs. Okay, okay. Thank you very much. So we are returning to the main session in the next 50 seconds. Okay, and by the way, this child is taking drugs. That's why if you've looked at the viral load, it's between 1,000 and 2,000 and 4,000 and 5,000. So there is some drug, because usually those children that are not taking at all, the viral load would have been way above 5,000. So there is some partial working of the PI in this case, but with poor adherence.
And
Not
maybe
so, Dr.
maybe poor dosing also.
Yes, poor dosing, poor adherence.
Especially what Mukumbi said, yeah.
Yeah, and because of and storage as well.
Mm-hmm.
Okay. Okay. I can attest to this fact that we had a good outing, and it's good to have everyone back. Maybe we start with AIDC. Any input from your end? Sombo? Sombo, are you online? Okay, yes.
So we'll let Mulea present what the team's thoughts were. She's a clinician here at AIDC.
Okay, great. Yes, go ahead, Mulea.
So for question 1, we discussed that the parents of the child also need to be involved, and care should not only be left to the grandmother. Maybe we should find a way of engaging both the mother and the father in the care of this child. Maybe that can help improve the adherence and the outcome. Then the other thing, since we already have people who visit this child, the CBVs, on that team, maybe a counselor can also do some home visits to offer the enhanced adherence counseling to the grandmother, and even teach the grandmother on the dosing also. So, then also communication needs to be improved, because since this child sometimes stays in different homes, then we need to improve on the communication, so that even as we plan as a team with the counselor, the CBV, and all, will find this child in at least in that home we intend to visit the grandmother or the parents. That's for question 1. Then for question 2, on question 2, we had both a no and a yes on MMS, multi-month scripting. So for the no, we said no, we should not engage multi-month scripting, because this child is not a stable child, since it has a high load. And also, we said no because of the storage of the calitria. If maybe we were to know the nutrition status and the weight, if the child who needs the syrup, they'll have difficulties in storing the syrup if you have to give them a lot of medicine. Then for the yes on the yes, this is when the child is we deal with this high load and everything is okay, then the child can be on every med. If the weight is good, that the child can be able to receive the tablets, the Anukia tablets and not the syrup. Then for the community, training the community-based workers, yes, they can be trained to do the weight and the calculating. When they do the weight, then they can calculate the dosage, or they communicate with someone on the facility so that they calculate the dose and they tell them which drug, which dosage they should give the child.
Okay, anything else before we go to Dr. Thomas? Sombo, anything else? Otherwise, that's quite comprehensive, very similar to what we had over here, but it would be good to hear what the other group had in their discussion. Dr. Thomas, over to you. Dr. Thomas? Okay, yes, Dr. Thomas, go ahead, please.
Hello, can you hear us?
Yes, we can.
Okay. I think,
Okay, they are almost the same answers, but we have mentioned on the community-based volunteers to be in mentorships, especially on taking weight. They should be going with the scale to take the weight of the child. And they should also be trained on the dosing chart for the drugs. We've also included that the child should be screened for active TB. If the child has no TB, then he should be initiated on INH for prophylaxis and also be given Septrin for prophylaxis. And we've also included other points like mitigating or addressing the challenges, especially the social challenges, where the mother should also be involved in the care of the child in case the child is with the mother. Looking at distance, the facility should do active outreach programs. If not, they should form community distribution points to distribute the ART for the baby or for the child.
Okay, is that all?
also maybe if the community health worker can be visiting this child every month, adherence can be reinforced. So that as we said before, that person should be trained on dosing chart. We can train them because we have done it on mentorship in other facilities. So in some afternoons, we used to call them, train them on the dosing chart so that they are able to understand. Some of them, they don't even know the name of the drugs, to read the drugs. So we have to equip them first and they can do that.
Okay. That's excellent. And of course, we also had similar responses like everyone else. They need to train these CBVs on dosing, and healthcare workers to be encouraged to go with the CBVs, at least to have an interaction with this child. And we were ably informed that they have tried that, but we just need to step up. And then engaging the family again for the treatment support, not just a grandmother like everyone has said. We know that the child has an interaction with the parents in one way or another when the child is visiting, so if those could be engaged as well. And then engage the very CBVs that are coming to collect these drugs so that they can also just try to educate the child on the importance, or the parents and the grandmother on the importance of adherence. So they offer adherence counseling at least while they are interacting with the child. And then of course, MMS may not be ideal in this particular case because of the issues that are obtaining right now. The child has very poor adherence. And something interesting again came up, of course. We do not know how this Caletra, which is a syrup, how it is stored. So the cold chain needs to be established in this particular case, how this syrup is being stored. So it may not just be the case of poor adherence. And then also offer self-centered DSD model, preferably a home delivery. That also came up. And of course, the CBVs or the assistants need to be trained. So training is very ideal in this particular case. However, our case presenter Gift brought out something while we were just here. Western Province unfortunately experiences cutoffs during rain season. So monthly visits become very, very much impossible, because that was one of the suggestions. If the healthcare providers can be making monthly visits with the CBVs before the child is thought to be put on MMS. So that is a challenge there, real challenge to all of us. So some areas are cut off, and during rainy season, it's just very impossible. So any other comment? I hope, Gift, we have heard the various recommendations that have been brought forward.
Sure.
So any other comment from the spokes? Dr. Chungu, I can see you are smiling.
Hi, David. Sorry,
Hi,
I
Sombo.
didn't want to comment a bit earlier because I wanted us to get the feedback from the team. I
Yes,
think
sir.
one thing that's very critical here is this
Sorry,
virus is in the.
your line is breaking.
Oh, I'm so sorry. Can you hear me better now? There's somebody else on the network who has the speaker on. Just
Yeah. Yeah.
Thank you. So I think take note of those bloods that this child has. He's moving 2,000 to 4,000. I think we need to acknowledge that this child is almost suppressed. He's not terribly failing these drugs. So there's a certain amount of knowledge that this grandmother has, and that this failure of getting to the facility or to the home is two-way, isn't it? The child can't get there, the facility can't, because they'll be broken off for some time. I know we suggested MMS. It's very clear this child needs a differentiated service delivery model. I think that one is very clear as to whether if a pharmacist can wear a child, you know that, a pharmacist can wear a child, adjust the dose. But I think the issue we need to look at is with the family as to how can we help the family now.
Sorry, Sombo, we've lost you.
To adjust the dose for that child, because whichever they won't be able to access a scale unless within the community. And we need to acknowledge that this grandmother is not the worst. This child is almost suppressed. So there's only just, it's not very knowledgeable that we cannot engage her further, is what I wanted to say. This child is almost suppressed.
Yeah, that's very true. Actually, that viral load of between 2,000 and 4,000 or 1,000 and 5,000 tells us that there is something in her, that the child is taking. It's not that they are defaulters or they are completely not taking anything. The child is taking something, and the grandmother should be commended, as you have said. But considering MMS in this child, that's very interesting because of the hardships that we have been. That may not be ideal in an ideal situation, but in this particular case, it's something that is worth considering. Yes, Dr. Chungu, your last words in less than a minute.
Yes, so thank you very much for all this input. I think it's been a great discussion, and once I will look forward to probably hearing like if we'll be able to source the tablet formulations from MSL, the 125. But just to underscore that on the priority action areas that I mentioned under the Rome Action Plan, 6 was optimizing pediatric regimen. And this child from the time was 2 has been on syrup, which could have been underdosed or which could have, not been stored properly. And Mukumbi in our breakout brought about issues of stability when you are considering MMS. Because even 3 months, even in a urban setting, is not the ideal storage condition for Caletra if you don't have, cold chain. So it brings me to another issue of the Lopinava granules that last time Prof. Mulenga was, the time I was in the hub, he mentioned that sometime in February or so, we might have Lopinava granules in country. So that's exciting for us, because for like far-flung areas, even within, it's a good solution in terms of stability and for measurements, and will ease the administration, and we can protect a drug as good as Lopinava. So this was a good case from Yuka.
Yes, and we totally agree with you. So we actually look forward to that great news, realization of having in country the granules, which will be a plus, especially on the pediatrics population. Any other comment before we close? St. Luke's, I know your hand is up. St. Luke's, just unmute yourself.
Thank you.
Yes,
we wanted to find out if
just tell us your name.
This is Elvis.
Okay.
Yeah.
Go ahead.
So I wanted to find out if there is an health post near the child is placed rather than the hospital.
Yeah. Okay, so let me answer.
Okay, so Gift, over to you. Yes.
Okay, so there is a health post that's nearer to this child than the hospital is. But I think if you've had some experience with clients that stay near mission hospitals or just the word hospital, people prefer to collect drugs from a hospital and like collecting from a rural health center. The trust that they have for hospitals is quite great that they wouldn't prefer getting drugs from those areas.
Okay, so based on that, I think it would be important that
it's muted.
Can involve the staff from that clinic, which is near to the home of that child, to try and help in terms of adherence and monitoring of the child. Thank you.
Okay, so there is a comment from one of us from the spokes. If the CBVs can pick up drugs and take to the child, why can't we consider asking them to bring the child to the clinic for some visits, which we can give the child other services like labs, etc. So by the way, we were told that if it means walking, they take about 4 to 5 days because it's about 100 kilometers from where they stay. Yes, Gift, your final words.
Basically, thank you very much for the comments that we've had. We're going to try and implement what has been said. Then we'll also try to work around and see other solutions that we can come up with. Then we look forward to presenting such a case on a positive end next time. Thank you very much.
Okay, so we shall definitely have a follow-up presentation on this one. And there's also one last thing before we go to Sombo. Has the facility tried to engage the community leaders or the Office of the Community Development looking at the comment on the child's nutritional status? What's your comment?
Not yet. The facility has not yet engaged that office, but we can try to see what we're going to engage them. The community leaders that have been involved are basically the CBVs, because some of them, they are community leaders where they come from. They are influential people, but then we might need to visit the office that has been just mentioned. It would be helpful.
Okay, thank you very much. Yes, Sombo, your last comment.
Davis, I have a burning comment.
Oh, okay. Go ahead, please.
Yes, so I think Elvis's comment is very relevant to say, despite the client persistently refusing to explore the health post, it's probably the most feasible and sustainable solution. So we need to continuously counsel them so that if we decentralize the service to the health post. I know it's an issue with the ART program where you have clients accessing, as far away as possible. But in this case, for the best outcomes in this child, it's possibly the most sustainable, the most practical, and the most desirable solution that we should strongly work towards as we do all those other things as well.
Simply put, St. Luke's has written, please, may we involve the staff from the nearest clinic to help take care of this child. So that's one of the recommendations, Gift Mwansa, that we need to fall on. This is more sustainable, especially that it's about 100 Ks from your facility. Yes, Sombo, your last comments in less than 30 seconds, then we close.
Okay, I just wanted to say thank you very much, Dr. Chungu. Thank you very much, Luke. That was a great case. But can Dr. summarize, because I worry when people say ESC, what would be your ideal package in an enhanced adherence care for a pediatric patient? What would be in that package?
Over to you, Dr. Chungu, in less than a minute, please.
Okay, so you know how we've been talking about an EAC model. I think we've been deliberating this over the past week. So the best EAC package is one that's centered around the individual needs of the client. So the guidelines provide for a minimum EAC client, which has 3 visits. But in some of the discussions we've been having, even with some of our mentors, is, client needs are diverse. So you find some of them, depending on their needs and what you find, you might need to have 2 weekly, 3 weekly, depending on the circumstances. So the best package would be one that's client-centered, of course, a minimum of 3 visits, and one that addresses the barriers that you identify in the taking of the medication, in the viral load suppression, in their interactions, and that optimally dose the child, weigh the child, and that result in them being suppressed. So we've been doing some work around seeing the effectiveness of EAC. Sometimes people don't even come for those EACs, but in the system, they're being captured as coming. So an ideal EAC is where you have that, it's being monitored, and the outcomes are actively tracked. So we're just saying we need to have the electronic systems as well as paperback systems that track the EAC for quality, not just for ticking boxes and saying that they're happening. But of course, that's a whole other big topic that needs to be explored further.
Okay, thank you very much. So just to quickly run through some of the things that are highlights concerning the recommendations. May we engage the parents, since they also have an interaction with this child as the child goes over, not just a grandmother, who of course should be commended for a relatively good job that she's doing. And then let's train the CBVs on the dosing and other related stuff as they manage this child. Then healthcare workers encouraged to have an interaction with this child monthly if possible, as the CBVs take the drugs. And then we may need to engage MSL also to see the possibility of providing a 100 milligram, 25 milligram tablet of lopinavir ritonavir, and then engage the family, as we have already stated, for treatment support. We may also need to engage the community leaders, to which Gift has said they will follow it up. Then the CBVs who come to get the drugs should also be told to actually emphasize the issue of adherence with the caregivers in this particular case as they deliver the drugs. And then let us also engage the staff from the nearest clinic so that they can help take care of this child. I think that is the highlight for me. We have a health post that is closest to the child's area of residence. Let us engage them, because they can actually even take up this responsibility that is becoming very difficult for us to continue managing this patient. And then we may need to offer a self-centered DST in this particular case, in this child. That's not the ideal for every other case, but this particular child may need some DST, especially given that at some time of the year, the area becomes impassable and it's very difficult to actually get to the patient's home. And the community health assistants need to be definitely trained. So that's just running through the 3 questions that we had, and I hope those are very okay and loud and clear. Otherwise, we'll get to you via email with the recommendations that have come through this afternoon. Okay, thank you very much, everyone. I hope you had a lovely time, and it was actually good to have Gift with us, and then Dr. Chungu as well, and all the experts or the panelists that joined in, and everyone that attended this afternoon's session, and for your contributions, which are highly valued. Please always keep them coming. Otherwise, for next week, we have the Vision 2020 for HIV program in Zambia, and that will be provided or presented by Professor Lloyd Mlenga. Otherwise, from all of us here, it's a good afternoon and see you next week. Thank you so much.
Thank you.